but I think we are just moving into this topic, requirement of for objective parameters, benefit of combining data, and the role of artificial intelligence. So let's discuss a little bit about this topic. And Renato, this is a study done by you and your group, and I found this really impressive. Can you go along this study?
I think I have to tell you a story about this study. We were in an ASCRS meeting, and people were discussing about ectasia risk. And the case number 6 is a pre-op of a patient that had LASIK ectasia. And you can see, the little yellow here on that. And some people would say, this is pathognomonic of a form-proof keratoconus. I would say
it's not.
This is pathognomonic because the patient had ectasia after LASIK. Then it's definitely pathognomonic. So you need a topography and a crystal ball to make this diagnosis. No, and then a debate. If you see this yellow because I have experience, and I say okay, and I got the idea of doing this study, sending the cases, so that people would classify, and people would be experts. If you see the names here, taking out the names of my fellows that were helping me at the time, all the colleagues here are experts, people that have published, people that go to meetings and present. And what we did was to send these cases, 25 cases, to these colleagues and ask them to classify based on the criteria of the ectasia risk score system that was published. So this is something that gives you a score, and the scoring is good because you get a number. You go from image to a number from an index, which is very good. But the number, the processing of doing that is subjective. So it's subjective classification. If the case is a form-proof, if the case is asymmetric, if the case has, and it skips the 2 because it goes from 1, which is a little bit asymmetric pulti, to the skewed radial axis to the more irregular. It skips the 2. So it goes in a very important way of looking at the weight of the topography pattern that the patient has. The interesting of the word surrogate, because surrogate means a substitute, and topography is a surrogate of biomechanical properties, but it's definitely a surrogate. It's a good indication, but it does not get close to what we should get from. But the data from 25 were classified by them, and I don't know if we have next slide, is going to see the second sending cases was with the same cases with a different scale. The first scale was the 1.5 diopter Steve Kleiss scale, and now this is a normative scale. In the Pentacam, this is called the holiday scale. This is a very much similar scale to the classic topography from the ISIS scale. And this topography scale is very much appreciated by many of my friends and colleagues around the world. And the same cases with different scale were classified different by, I remember it was 9 of the 11 classification colleagues. Even myself, I changed the order and did the classification, and I missed the classification in 7 out of the 25 cases. I changed my classification. So this is something that we have to be really aware, that the variability of the classification on the subjective domain is huge, and it changes based on many factors. We tell people about, when you are seeing this patient, depending on when you're seeing this patient, you may change your classification. So this is a very important issue, and we need to be objective.
I think this really explains how important it is to have objective criteria and numbers. So, Renato, of course, then perhaps you can comment on the idea of combining tomographic and biomechanical data without going into all the details of the artificial intelligence.
Yes, the importance of artificial intelligence is everywhere in our lives. When we use any smartphone, when we go into Google, we are surrounded by many artificial intelligence, and will be more and more with the time that is coming with more integration. So artificial intelligence is very important to integrate data, because in our human minds we think in a linear way, and the data is very much complex, and of course we have to be careful on believing and training artificial intelligence. But this is important to really be aware of the power and the importance of the random forest, for example. So we have hundreds of parameters, and we should exclude the parameters that are not so important, and eventually get the information together so that we can make a good decision.
Yeah, so the tomographic biomechanical assessment, you see here on the slide how it works. So yeah, you basically have a Pentacam and a Corvis exam, and they are combined. Okay, so Riccardo, can you explain the viewers what they see here on the tomographic biomechanical assessment and how it works?
Well, I'm just going to make an introduction, because I think that the man that needs to speak about this is Renato.
Yeah.
So here we have a combination of tomography and biomechanics, but what is my main thing that I want to add, that is a very frequent question in all the congresses we go, is that the TBI is much, much more sophisticated than just combining the two indexes above it, so CBI and BED-D. So the TBI is a pure combination of biomechanics and tomography. So the single parameters that we can get from each instrument combined together with a very sophisticated artificial intelligence to go to a new index. And that is the reason why, in some cases, very few, but it's still possible, you can have CBI and TBI that they don't speak the same language. So one can say one thing and the other can say another thing. And that is simply because they are made in two different ways. Maybe Renato wants to comment a little bit more on that.
Yeah, but you beautifully stated, Riccardo. It's exactly this. We have linear regression, and we have more sophisticated ways of doing artificial intelligence. Basically, what we say as artificial intelligence is training the computer to create a method of thinking like what we would think, and eventually it goes much more effective. So we have different ways of combining data, and when we tested all these ways, the random forest was really the best way of doing it. That time we used the leave one out cross validation, which you have a population, and for that you exclude one, and then you train the best model and you apply in that one that is excluded. And you do that multiple times. That's the leave one out cross validation. It's a very tedious process, and of course we cannot do that. We have to have a program for doing that, and you have different artificial intelligence tools that can do that. And once you have the leave one out results, this is going to be validated. The model is going to be validated, the model with the parameters that you have. So once we have this model, you train for everybody, and then you have very much well-trained random forest for that population, which is virtually perfect. The issue is going from this to the next population, to the external validation. And that's very important. And as you said, the random forest with leave one out is a much more complex way than the linear regressions that we have on the BED-D and on the CBI. It's possible to do random forest for the tomography, yes, and we have the Pentacam random forest index, and eventually we have an enhanced parameter that I'm doing with my colleagues of the brain. But the beauty of this is that we can always evolve. That's why I say, the reason I say it's a revolution in continuous evolution. So and you can improve in two ways: having more data, more parameters. Like if you have wavefront data from the Pentacam AXL wave, that may be integrating this algorithm better. But we can also improve by having more cases, and that's the enhanced optimized that we did with the international work.
Yes, Renato, we will speak about the next generation as a next topic. Perhaps let's first speak about the current version of the TBI. And this was your initial study that you came up, right?
Yes, we collected cases. We agreed to collaborate, myself and Paolo and Riccardo Vinciguerra. So we combined the data, and we understand that combining the data, we will have a much more impressive population to train and to do the testing. So the first study was with 480 normal eyes, 204 keratoconus cases, and you see these bars here, the complete separation. And we use one eye randomly selected from these patients so that we can get the best method as possible. But we also included 94 cases that had ectasia in one eye, and the fellow eye had normal topography based on the objective criteria. Again, the importance of the objectivity, because the KISA had to be lower than 60, IS value lower than 145, central K less than 47, and no TKC on the topometric keratoconus detected from the Pentacam. So these cases also came with the fellow eyes that had ectasia, but some of these cases already had done cross-linking or rings or transplants in our clinics. So we combined the data and we trained this population with the leave one out cross-validation. And for the clinical keratoconus, the red and the dark red, you had a perfect separation with a 0.79. It's a very high cutoff value. But when we want to separate the greens from the oranges, which are the normal topography eyes from the very asymmetric ectasia cases, we had a very good sensitivity of 90.4% with a cutoff value of 0.29. So this is very much important so that we can see the optimized cutoff value. And if you click once more, I think it's coming with a concept that from the stability towards the disease, we have an epitomized value of the susceptibility of the likelihood of ectasia progression, which is the main reason we are looking at the integrated data.
Yeah, and perhaps I can also comment from the Oculus point of view. This is also the reason why we did make a color gradient. So we didn't make just a green, yellow, red, but a gradient from green over yellow to red, because it's a continuum. So let's get the panel again into the discussions.
If we speak about another technology, which is epithelial maps, what is the benefit of having more data and role of indices? So epithelial maps, we all know that they are nice and they're very useful. But the problem with that technology is that we don't have a cutoff. We don't have indices. We have only a map. And all the time, we all think that epithelial maps are great. They're very nice. They're very interesting. But if you don't have an index, if you don't have some kind of artificial intelligence that is creating something that you can validate, because if I say epithelial maps are the way to go, I screen all my patients with that, and Renato is saying, well, it's not the way to go, there is absolutely no way to demonstrate I'm wrong or he is right, because there is no objective way of saying if that technology is useful or not. So that's why we need indices, and this is why we need artificial intelligence, and that's why we need more data.
Then let's continue with a case, with cases again regarding this topic. Renato, this is a case sent in by you, and I think this is also a very nice case illustrating the benefit from artificial intelligence.
Yeah, this is a very interesting case. This patient comes first. There are twin sisters, identical twin sisters. If you click once more, you appreciate that the front surface curvature map from the placido disc topography, the Keratograph 5, which is a beautiful color topography system, is exactly the same as the Pentacam topometric Scheinflug map. So we have a curvature data that in the right eye of the first twin is clearly a very mild keratoconus, but it is a very keratoconus unquestionable appearance. The TKC is abnormal, and this would not even meet the criteria of the TKC. This patient was not part of any study to train the system, which is very important because once we train the artificial intelligence in the training population, it's very likely that the algorithm will be very powerful, very effective. We have to look at the data, how it applies in the next population. So in the normal topography eye here is even the patient has a TKC of yellow, but this is very asymmetric. And she told me, I have a twin sister, and I told her immediately, so we have to bring her in and we got her free consultation for the sister, and probably was one of the most interesting things that we ever seen, because both eyes of the second twin are exactly the same. Mm-hmm. And this patient is a bilateral form frust, as we can speak of. So the TBI was very much abnormal in the right eye with a keratoconus in the first twin, and it's 0.58, but you can say, oh, Renato, see here, the TKC is already yellow, the IHD, which is index of high decentration, is abnormal, so the front surface will be okay here to detect the disease. Okay, yes, but when we see the 0.58, it's much more abnormal. So that is more confidence on the data, and both eyes of the next twin. And interestingly, we have the information that she admitted to rub the right eye more than the left eye, and both admitted that the first twin rubs the eye more than the second twin. Mm-hmm. So this is a very good example of bilateral susceptibility in the identical twin sisters.
Shizuka? Yeah, perhaps you can also comment on this case, but also what is the importance for you having these objective criteria? How does this artificial intelligence method is supporting you in your practice?
Definitely, I think objective criteria and cutoff values are very important when we see the patient such kind of very borderline cases, and sometimes actually, okay, some doctors say that it's kind of normal, but some doctors say that might think actually this is abnormal. So today, can I show you? Can I show some of our cases?
Yeah, we will go through the cases now step by step, right? This was a case which, Renato just presented. And yeah, let's start with this case from Renato also, but we will go to your cases in a minute as well. Renato, what about this case? I mean, this is now, I think a case where artificial intelligence really could save the life, right?
Could have. And this is 2014 that I saw this patient, and she comes with a fairly high myopia, -9, and we decided to do SMILE for her, and she did beautifully well. She was 20/20 minus a couple of days after surgery, beautiful surgery, and everything was looking good. The patient comes back, and this is the Pentacam pre-op, and you see, again, remember the case that Riccardo just shown, 1.07 here in the D, but the artmax is 382, but we were kind of confident on the benefit of SMILE with a low biomechanical impact, lower biomechanical impact than LASIK. But this patient, in both eyes, she has not a very bad situation. In the right eye, 1.27 of the BED. And once this is also the QS this is a very important tip. The QS is the quality score of the tomography system. And sometimes you have multiple times the exams and you don't have a very good fixation, a very good quality. This is by itself a good sign of something is not perfectly well in this case. But we did go well, and this patient did well for the first years, and she comes back in 2017 with ectasia, 17 or 18 with ectasia, so 3 years after that. And we had the data, we had the Corvis data, because I do Corvis in everyone because it's a very good tonometer, and we had that data installed. And this data would be retrospectively good for the analysis of the TBI, and the TBI was 0.73. So this is a very good example that the susceptibility of the cornea would have been detected. That's exactly my first ectasia case, and I learned a lot from this case. We can discuss many things about how to discuss about the complication and how to manage the complication. There's another story, but what's the best treatment for ectasia? The best treatment for sure is to prevent it. In this case,
is it a typo? This one that is post LASIK is post SMILE, right?
This post SMILE, yes. Sorry.
Okay.
Yes. And I think this slide is already post the ring. No, it's not. We don't have the ring yet. It's it's still. And I did a cornea ring, and this patient did very well. And the patient is and understands that she cannot rub the eye. The left eye did not have ectasia yet, and it's still stable with a good vision and correct vision.
Mm-hmm. Renato, this is an impressive case. It's really nice.
Yeah, we are working on thinking about the publication, but I want to have her out of the ring for at least 3 years, and I think it's coming now.
Was the CBI LVC abnormal even in the early post-op?
It's a very good question. It's a very good point, but I didn't look at that. I looked at the posterior elevation in the 2 years post-op when she was doing really well, and I would have been able to see the abnormality there. But this is even something we don't have that. We don't look at the posterior elevation maps in every very much post-op, but that would be a good sign for indicating the early changes. And but the patient did not come back for a couple of years, and then when she comes back, she had a very dramatic drop of vision from 20/25 plus to 20/100, and then we easily detected by topography the abnormality.
Okay, yeah, this is very impressive case. I think we will go on with the next topic, speaking about cutoffs, because if one has artificial intelligence and objective number, one needs also to know cutoffs. But I would like to try once more to bring Professor Zhou into the discussion.
This is very impressive post-SMILE ectasia case. I and my team have been performed more than 100,000 SMILE procedures, and we did find 2 cases with post-SMILE ectasia. So I really love to know every data about the Pentacam combined with Corvis ST, how to pre-screen to provide us the significant index. As I would like to ask Renato, is this case with the SMILE, the TBI is 0.73?
Yes, if Sven can go back a couple of slides, you see the in 2014 we were not. Yes.
So in terms of the topography, including the bedding screen seemed normal. We accept the TBI order more than 0.5, right?
Yes. If Sven can show the TBI of the right eye, which was the eye that had ectasia. Yes, that's the one.
Yes.
You see
yes.
the topography
but the CBI is only 0.34.
Yes. The CBI is, this patient does not have keratoconus. What she has is a moderate susceptibility, and the moderate susceptibility plus the -9 smile case plus the eye rubbing lead to the ectasia progression.
I think it's important to say, though, that if you look at the quality score of the Corvis, there are some lost points. So obviously, well, the CBI here is normal, but we don't know if with all the points we could have a different CBI. It's not, we can't know.
Yeah, we agree with the TBI is most important for us. So as for me, in recent 3 years, we didn't do lamellar surgery for TBI over 0.5. So in practice, sometimes as for the corneal thickness less than 520 microns, I will pay more attention of the TBI. So that's what I thought is the key point of the CP. The TBI is most important for the surgeons.